Okay, let's dive into this. When you're facing an undifferentiated poison patient, your very first move? It's pattern recognition. You've got to rely heavily on vital signs and the physical exam. We're going to sort these patients rapidly right now, focusing entirely on the exam-facing decision logic you need as a third-year medical student. We're breaking down exactly how to differentiate exposures, mechanisms, and those definitive clinical clues that actually drive your management.
Your primary clinical split begins the second a patient rolls into the trauma bay. Picture a patient presenting dry, hot, with mydriasis, blown out, dilated pupils, and urinary retention. That is your classic anticholinergic toxidrome. Now contrast that immediately with a patient who is literally dripping wet, leaking fluids from everywhere, with severe bronchorrhea and meiosis, those pinpoint pupils. That's your cholinergic toxidrome. Recognizing this massive clash of autonomic extremes is the absolutely essential first step in stabilizing your patient.
From there, we look at the next critical clinical splits. If a patient presents with altered mental status, grab an ECG immediately. Why? Because differentiating altered mental status paired with QRS widening from just isolated sedation is exactly how you separate lethal cardiotoxic agents from your standard sedative hypnotic overdoses, like benzodiazepines. Similarly, when you're looking at labs, you need to separate massive transaminitis, which points straight to pure hepatic toxins, from complex mixed acid-base derangements. Specifically, pulling apart a respiratory alkalosis combined with a metabolic acidosis will point you toward a completely different class of toxins.
Section 1. Autonomic clashes. Anticholinergic versus organophosphate toxicity.
Let's start with the exact physical manifestations of muscarinic blockade, better known as anticholinergic toxicity. The mechanism here is a widespread blockade of glandular secretions and smooth muscle contraction. You are looking for decreased bowel sounds, flushed, bone-dry skin, and hyperthermia. The patient will have mydriasis causing blurry vision, urinary retention, and significant tachycardia. And then there's the central nervous system involvement. This leads to that classic Mad as a Hatter presentation. Guys, this isn't just mild confusion, it's severe agitation, delirium, and a super high risk for seizures.
And this brilliantly illustrates the common triggers we have to watch out for. We're talking antihistamines like diphenhydramine, tricyclic antidepressants, anti-Parkinson drugs like benzotropine, antispasmodics like oxybutynin, and mydriatics such as atropine and scopolamine. Oh, and definitely don't forget plant exposures like Jimson weed. While supportive care is central to your management here, physostigmine, a cholinesterase inhibitor, can actually be used as an antidote to reverse severe, pure anticholinergic delirium. But, and this is a massive warning, you must strictly avoid it if you suspect TCA toxicity or any underlying conduction disease because it can literally precipitate cardiac arrest.
Flipping to the exact opposite end of the spectrum, we've got organophosphate poisoning. The mechanism here? It's acetylcholinesterase inhibition, and that leads to a massive excess of acetylcholine at muscarinic, nicotinic, and CNS receptors. Muscarinic findings are incredibly wet. We're talking diarrhea, urination, meiosis, dangerous bronchorrhea and bronchospasm, along with bradycardia, emesis, lacrimation, and salivation. Nicotinic findings, on the other hand, affect the muscles, presenting as fasciculations, weakness, and paralysis. Treatment requires a very strict sequence. First, get all contaminated clothes off and irrigate the skin. Secure the airway and give oxygen. Then give atropine immediately to reverse those life-threatening muscarinic symptoms like bronchorrhea. Only after giving atropine do you give pralidoxime, which regenerates acetylcholinesterase before irreversible aging of the enzyme happens.
Moving on to cardiotox and CNS alterations, specifically focusing on TCA overdose.
The mechanism of a TCA overdose is a really dangerous combination. It causes both sodium channel blockade and anticholinergic effects. Clinically, you'll see delirium or coma, seizures, hypotension, sinus tachycardia, dry mouth, urinary retention, and mydriasis. But your critical clues? Those are on the ECG. The sodium channel blockade leads directly to QRS widening, prolonged PR and QT intervals, and a very, very high risk for fatal ventricular arrhythmias.
So the crucial point is that your first-line treatments absolutely must target these exact physiological threats. You've got to provide immediate airway support. If the patient is seizing, hit them with benzodiazepines. The specific targeted therapy for that cardiac toxicity is intravenous sodium bicarbonate. You give this specifically to overcome the QRS widening or ventricular arrhythmias. The massive sodium load essentially outcompetes the sodium channel blockade, and the alkalinization makes the TCA way less pharmacologically active.
Next up, hepatic and acid-base toxins. We're breaking down acetaminophen and salicylates.
Acetaminophen overdose follows a very specific destructive chronology. It kicks off with the depletion of glutathione in the liver. Once that glutathione is gone, highly reactive, toxic metabolites accumulate super rapidly. This direct oxidative renal and hepatic toxicity basically culminates in acute liver failure. The absolutely critical complication you need to remember is this. If you see worsening acute liver failure despite treating with the antidote, N-acetylcysteine, that patient needs a rapid referral to a transplant center right away.
Now, what's really interesting about this slide is how precise the testing and treatment timing is. If a patient presents early, and it's safe to do so, give activated charcoal. But the definitive diagnostic step is checking the serum acetaminophen level at or after 4 hours post-ingestion. If you know the exact timing of the ingestion, you plot that level right on the Rumac-Matthew nomogram. You give N-acetylcysteine if the level falls above the treatment line, if the timing of ingestion is completely unclear but the level is detectable, or if there's literally any clinical evidence of liver injury whatsoever.
Salicylic toxicity, on the other hand, presents completely differently. You're looking for a patient complaining of tinnitus, vertigo, vomiting, fever, tachypnea, and altered mental status. The absolute signature diagnostic clue here is a primary respiratory alkalosis driven by hyperventilation, combined with an elevated anion gap metabolic acidosis driven by lactate and other organic acids.
Managing salicylate toxicity requires an exact sequence. Give activated charcoal if the ingestion is acute, early, and the patient is alert enough to protect their own airway. Your primary medical therapy is IV sodium bicarbonate. This alkalinizes both the serum and the urine to trap the salicylate and dramatically enhance its excretion. You also need to know the strict indications for hemodialysis here. We're talking severe disease involving pulmonary edema, acute or chronic renal failure, and persistent acidosis despite bicarb therapy. Watch closely for shock, seizures, or any rapidly worsening condition.
Finally, our last grouping, heavy metals and corrosives. Let's look at lead and magnesium side by side. Lead poisoning often presents with chronic abdominal pain and neurocognitive changes. The diagnostic absolute rule for lead is that a screening capillary lead level must always be confirmed with a venous sample. Treatment involves heavy public health and environmental action, with chelation therapy deployed depending on the specific blood level. Magnesium toxicity, which we often see from clinical overadministration, presents with hyporeflexia, weakness, respiratory depression, hypotension, and bradycardia. Treatment is immediate. Stop the magnesium, push IV fluids, use loop diuretics, and administer IV calcium specifically to reverse those severe symptoms. Dialysis is kept in reserve for only the most extreme cases. Arsenic poisoning leaves a highly specific clinical footprint. The mechanism disrupts cellular respiration, leading to acute symptoms like garlic breath, vomiting, watery diarrhea, and QTc prolongation. Chronically, you're going to see severe GI distress paired with a classic stocking glove neuropathy. Look really closely for pigment changes and Mies lines. Those are the horizontal striations right on the fingernails. Treatment requires specific heavy metal chelation with either dimercaprol or DMSA.
Let's move to and see how this builds when we compare it to the physical destruction of caustic ingestions. Alkaline substances, like heavy-duty cleaning supplies, cause acute liquefaction necrosis that penetrates incredibly deep into tissues. The immediate presentation is severe pain, oral burns, and dysphagia. But the most common delayed complication is the formation of esophageal strictures weeks to months later. The absolute most important management rule here is what you do not do. Absolutely no gastric lavage, no inducing vomiting, and definitely no charcoal. You will either re-expose the esophagus to the corrosive agent or cause catastrophic aspiration. Management purely relies on securing the airway, decontaminating exposed skin, getting a chest and abdominal X-ray, and performing an endoscopy within 12 to 24 hours to assess the damage.
Navigating toxicology isn't about perfectly memorizing every single antidote. It requires strict adherence to clinical priorities. Secure the airway, decontaminate rapidly to stop the exposure, and only then deploy targeted reversal agents. Master this exact sequence, and you can confidently stabilize any poisoned patient that rolls through the doors.